Hello, good evening, everyone. I don't think the mic's on yet. Is it? Oh, good. Oh, good evening. I'm Gia Metherell, President of the Canberra Mothercraft Society, and it's a great pleasure to welcome you this evening on behalf of the Canberra Mothercraft Society to our 2023 Mary Kirk Fellowship Lecture. I'm assuming we're underway with the Zoom project upstairs. CMS pays its respects to the Ngunnawal people, the traditional custodians of the land on which we meet tonight, and to any other people or families with connection to these lands. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region, and the role they play in birthing and nurturing their families on this land. We would also like to acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be here tonight. We're very honoured to have with us this evening to launch tonight's lecture, Minister Rachel Stephen-Smith, who's the ACT Minister for Health, for Families and Community Services, and for Aboriginal and Torres Strait Islander Affairs. And we're also very privileged to have as speaker Professor Leonie Segal from the University of South Australia. I'd also like to acknowledge the Director General of ACT Health, Rebecca Cross, who's in the audience this evening. There are also a number of senior ACT and federal government officials attending, including from Canberra Health Services and the ACT Health Directorate, ACT Community Services and Directorate, the ACT Human Rights Commission, the Federal Department of Health, and from the Office of the Minister for Social Services, Amanda Rishworth. I'm pleased to say we have as many, actually more, attendees online as are here tonight, and we'd very much like to welcome those joining us on our live stream, particularly the National Children's Commissioner, Anne Hollands. We also welcome office bearers from the Australian Research Alliance for Children and Youth, Mary Mead Catholic Care, Uniting Care, Berbera, Relationships Australia, Redanthi Lipset Indigenous Midwifery Charitable Fund, Roundabout Canberra, and the World and Australian Associations for Infant Mental Health. I must also mention the presence of CMS Life members, including our former Executive Officer, Mary Kirk, in whose honour the fellowship is named, and Dr. Sue Packer, 2019 Senior Australian of the Year, both tireless advocates for women, children and families. CMS is one of Canberra's oldest non-government organisations, now approaching its 97th year, and was the first to provide primary health services to families in the ACT. At its peak in 1969, it was running 32 mothercraft clinics, 2 occasional care centres, and the QE2 home for postnatal care. While CMS stepped away from QE2 in 2019 and is no longer involved in direct service provision, we continue to work with partner organisations and remain unwaveringly committed to improving the health of women and children and ensuring the well-being of families. That commitment underlies the establishment of the biennial Mary Kirk Fellowship, of which Professor Segal is the second recipient. Tonight's lecture on a topic of the utmost significance to vulnerable women, children, and families, and indeed to the wider community, is a mark of that commitment. Before calling on the Minister to launch the lecture, I'd ask you please to please silence your phones if you haven't already. Thank you, Minister.
Thank you so much, Gia. Yuma, everybody. I also want to start by acknowledging the traditional custodians of this land, the Ngunnawal people, and I recognise any other people and families with a traditional connection to the ACT, and acknowledge that As Gia said, Aboriginal people have been birthing and raising their children on this country for millennia, and the sovereignty of this land was never ceded, and we have much to learn from the traditional custodians here. I won't go through again and acknowledge everyone who is here as Gia has, but I do want to specifically acknowledge Mary, Kirk and Sue Packer. It's lovely to see you this evening, and it's lovely to be here to help to launch this lecture. And I want to thank the Canberra Mothercraft Society for the opportunity to launch the second Mary Kirk Fellowship Lecture and to highlight the work of one of Canberra's longest running non-government organisations, the Mothercraft Society. This fellowship, of course, honours Mary Kirk's contribution to the field of midwifery locally, nationally and internationally. The fellowship aims to improve the understanding of issues affecting the health and well-being of women, children and families. And the inaugural Mary Kirk Fellowship was awarded in 2021, and now Professor Leonie Segal is here tonight as the second well-deserved recipient of this fellowship. Tonight, Professor Segal, who is a leading researcher in the field of intergenerational trauma, will discuss the system changes that are required to address the disadvantage faced by infants, children, adolescents, and young adults who are exposed to abuse and neglect. Professor Segal highlights that child abuse and neglect should be regarded as a key public health issue. And her research demonstrates that children of parents who have suffered from serious abuse themselves are also likely to suffer similar abuse and harms. Children and young people are, of course, not always recognised as victim survivors of domestic and family violence in their own right. But the ACT government has been taking steps to better understand these issues. And it's clear from the government's consultation with children and young people, led by Jodie Griffiths-Cook, the Children and Young People Commissioner, who's here this evening, that prevention, early intervention responses and healing strategies must be tailored to young people's needs, and how vital it is to hear the voices of children and young people in this conversation. The Jodie Griffiths-Cook's report, if you haven't read it, now that you've heard us, what will you do? It is really eye-opening in some of the things that children and young people say about the impact of family violence on them, and what they wished adults had done when they were having these experiences. So we have undertaken a range of initiatives in this area. In July 2022, the ACT government launched the ACT Domestic and Family Violence Risk Assessment and Management Framework to support better coordinated responses by ensuring that all service providers understand the impacts of domestic and family violence and are able to appropriately respond to victim survivors and also to perpetrators. This approach is aimed at improving outcomes for victim survivors, as it is known that they are more likely to disclose to a trusted service provider, which may not always be a specialist domestic and family violence service. One of the other things we know is that if someone discloses once and gets a very poor response, they may never disclose again, or it may take some considerable time. In 2022 as well, of course, the ACT government launched Maternity in Focus, a consolidated action and implementation plan committed to improving the health and satisfaction of women and pregnant people. This plan provides opportunity to work with vulnerable groups, such as those experiencing family and domestic violence, to better understand their individual needs and to ensure that the system is safe, inclusive, appropriate and woman-centred. Additionally, the ACT government established the Family Violence Safety Action Pilot in 2021, and this collaborative service brings together a range of specialist domestic and family violence services, as well as criminal justice agencies, housing services, and other victim support services, both government and non-government, with the aim of improving information sharing and case management. The initiative was expanded in 2022 with the addition of a cultural liaison officer and an Aboriginal liaison officer to improve services for culturally and linguistically diverse and Aboriginal and Torres Strait Islander clients. And also during 2002, the ACT government provided specialised training through the Stopping Family Violence program, an expert provider. The justice and legal sector, community and health sectors, and the domestic and family violence sector were all enthusiastic participants in this program. We also have a program around strengthening hospital responses to family violence, leveraging trusted healthcare settings where people experiencing family violence can access support. Safe conversations with health professionals can identify risks early, as well as provide a connection with community services, including domestic violence crisis service. And in that vein, finally, we're very proud of the work that we've done to establish and sustain the health justice partnerships. Under this program, lawyers come to healthcare and community settings to meet and provide legal support to clients who are experiencing domestic and family violence. In 2021, the ACT government committed $4.1 million over 4 years to ensure that this successful initiative can continue. And to date, the program has helped more than 1,000 women. But despite this program, all of these programs and all of this work, we know there is still more to do, as Professor Segal's research demonstrates. So I really want to thank the Canberra Mothercraft Society for its tireless work in the areas of health and wellbeing for women, children and families. And I look forward to hearing the lecture and learning more from Professor Segal. This is obviously something that spans across all of my portfolios of health, families and community services and Aboriginal and Torres Strait Islander affairs, and the health and wellbeing of children and young people who are experiencing neglect, abuse and disadvantage is very close to my heart. So I'm looking forward to the lecture this evening, and thank you all for having me here to launch it.
We'll do two in one. Thank you, Minister, for those words, and thank you for all your efforts, the efforts that you are making in dealing with the problems that we as a society face. It's much appreciated. We know they're complex and deep. Professor Segal is sorry, I keep saying Segal, but I mean Segal, is the Foundation Chair, Health, Economics and Social Policy at the University of South Australia, and an internationally recognised scholar on the mechanisms of intergenerational trauma and its devastating lifelong effects. She's a passionate advocate for radical change in our response to dealing with children exposed to child abuse and neglect, whom she believes that we as a society are failing. I'll hand over to her now, but before I do, let me say that when she concludes the main part of her speech, there will be time for questions and microphones will be handed around. Please wait for a microphone because the people on the Zoom will not be able to hear your question otherwise. So over to you, Leonie. Thank you.
Thank you to the Mary Kirk Fellowship for giving me this opportunity to, I suppose, have an audience to talk about the work that I've been doing over the last 15 years. And I have to say it's been a challenge to try to fit 15 years of work into 40 minutes, but we'll see how we go. It'll be quite a ride, I think. I also like to acknowledge, I think there's a lot of wisdom in this room. So I'm very interested to, not even just question, but comment as well, because I think there's a lot we can all learn from each other in this very sort of challenging space. And it's an area that we've all been I suppose very committed to is how to really create a better future for our most vulnerable children, and what we can do to disrupt the harm cascade. Also, I think it's quite an opportune time with now sort of moves to develop an early childhood strategy, focus on the first 1,000 days. So it seems like, hopefully we're at a tipping point where actually something can change, because I think people have been concerned about these issues for a number of years. People on the ground are working very hard, but often don't have the systems and structures and resources to enable them to do what they need to do. So part of what I'm trying to do, it's also about advocacy. It's saying this is the harms we're facing. This is the cost we're incurring. We have to do something different. And we need to do something different for our young children. So broadly, what I'm covering is a bit about the pathways between child abuse and neglect and poor outcomes. So they're now well described, but if we understand those mechanisms, we're in a much better position to disrupt them. So that's really where I always start with my work. The second thing is to look at the size of the impacts. And I think really before our work, I don't think people realise just how, I think at perhaps some core level people might understand, but the data we're coming up with is truly shocking in terms of the impacts, and I'll take you through that. And then it's really clearly what we're seeing is unacceptable at every level. So we must do better, and here's some sort of thoughts about how we can progress this. And I'm sure there's lots of wisdom in the room also about that. So in terms of causal mechanisms, it's now absolutely incontrovertible that there is a causal pathway between child abuse and neglect and poor infant and child development, poor health, social, economic outcomes across life and intergenerationally. In fact, every single outcome that's been looked at, health, social, economic, related to child abuse and neglect, there is always an impact. It has such a pervasive effect on the developing child. And as I said, understanding these causal pathways is important to inform what we can do. So this sort of, I look at the causal pathways in three broad categories. So the first one is actually just the direct impact of physical and sexual abuse and neglect. So with serious, profound neglect, health conditions are ignored, children get sicker. Their basic needs for sustenance and supervision aren't being met. Exposure to harmful substance. So we have fetal alcohol spectrum disorder. These are the direct examples of profound neglect and serious abuse. In addition, there's a whole sort of physiological cascade in terms of heightened stress response for children who are continually on high alert. You end up with sort of issues around inflammatory markers heightened the whole time. And also basically their brains develop differently, that, when you're sort of continually in this stress situation, there's evidence to suggest that effectively so essentially it means that capacity for the sort of executive function, that part of the brain is less developed, and it's more the emotional response. So we're looking at really very serious impacts. And in addition, and some work that particularly with my colleague Dr. Jackie Amos, child psychiatrist, have contributed significantly to this literature, is actually understanding that children and infants, toddlers, children brought up in a family environment which is very disturbed and distressed, they develop a whole different relational model. So for them, when they're not safe, they're continually in this space of hypervigilance. It's very hard for them to develop any sense of compassion, because as soon as they let their guard down, they're going to be in trouble. So we end up with this category called agonic mode, which is very about dominant, submissive, and it's a sort of self-protective space children go into, families go into, when there's this very distressing relational stuff happening. And that's a bit, and this is core to explaining why we've got this intergenerational transmission. So in this agonic mode, it's very threat-based, everything's win-lose, no compassion, highly shame-based. It's about shaming the other. Children's feelings and emotions aren't validated. It tends to be about the parent's emotional state. So it's very hard for this person to develop a sense of agency, to develop a sense of self. And it's very difficult to then improve your lot in the world if you don't have sense of agency and sense of self. And the other thing is that these pathways are actually mutually reinforcing. And I think that's one of the reasons we're finding such huge impacts. So we end up with people generally hugely, acutely shame-based, underdeveloped sense of self, often enmeshed parent-child relationship, limited sense of agency, huge difficulty with emotional regulation, poor impulse control, on perpetual high alert, easily triggered, high levels of unmanageable distress, failure of empathy and compassion, and poor ability to plan and focus. What's interesting when you look at these characteristics, they map onto attributes of mental illness and other chronic disease. And we do find, and I'll show in the data, hugely increased likelihood of mental illness. If we actually want to do something about mental illness, we need to start with our infants and toddlers in these situations. Don't wait till we've got a teenager who presents with their first psychotic episode. And what do these sort of attributes predict? They predict compromised ability to learn, and you'll see that in the data. Reduced employability, you'll see that in the data. Welfare dependency, unstable housing, high-risk behaviours, substance use and other addictive behaviours, partly to self-medicate and self-soothe, bullying and criminal behaviour, incarceration, difficulty with intimate relationships, family violence, compromised parenting. So all of these are going to map onto our intergenerational transmission of child abuse and neglect. So we have to intervene early before, ideally before these children become parents. So in sum, the pathway is child abuse and neglect changes how brains develop, has a stress response, comes to a sort of a relational patterning, which is protective in that acute situation of abuse, but actually undermines their capacity to develop fully and really take control of their lives in a way that they'd really want. So it affects behaviour, emotions, emotional regulation, cognition, impulse control, alertness to threat. These in turn affect ability to learn, substance use, criminal behaviour, and we end up with these massive mental and physical health, social and economic consequences. So that's sort of, in a sense, the theory. And then what we've done is look at what is the size of the harms. Can we use this to then really make the case we absolutely have to do something different, and it will be economically sensible, will save more than it costs us. So most of this work is based on study in South Australia, where we looked at data on children born from 1986 through to 2017. There's over 600,000 children or persons in our data set, of which depending on the sort of years, between 20 and 25% have had some contact with the child protection system. That's our way of assessing whether people have been in a abusive or neglectful situation. It doesn't map exactly on to child protection contact, but it's quite close. Substantiation, so roughly 5% have had substantiated abuse and neglect, and something like 2% have ever been in out-of-home care. So this is the data sets we've linked. Death data, child protection, perinatal, birth certificates, Centrelink, so benefit payments, education and child development, so school census, NAPLAN, Australian Early Development Census, and hospital inpatient and emergency department data. So there's been a team of people over about, it took us probably 8 years to actually get the data. So some of us spent quite a lot of time doing that. And then there's been a number of us working, probably most recently, Crystal was working as an honours student to look at the AECD data. So we'll start off with the education and child development. We've looked at absenteeism and the Australian Early Development Census, which a lot of you will be familiar with. So if we start with the Australian Development Census, so this is looking at psychosocial development at the first year of school, at second term of school, it's basically teachers' assessment. And these are the sorts of questions. So, how would you rate the child's overall physical development? How do you rate their ability to get on with their peers? Can they solve problems by themselves? Can they demonstrate self-control? Do they accept responsibility for their actions? Do they fight with other children? And then this straight learning, things like letters and sounds and numeracy questions. Now, what we've done here is the vulnerable is the bottom 10%. So essentially, children in this second term, if they're vulnerable, then they're what we also know is that their progress through school will be compromised. So what we have here is on the left, so there's 5 different domains: physical, social, emotional, language, and communication. So on the left-hand side, we have children who have no child protection contact, and we go from left to right with more, if you like, serious suggestions of child abuse and neglect. So even for children who've had a notification only, we're looking at much higher rates of vulnerable. This is the situation for boys, and you'll see that the red bar, which is children who've entered out of home care before they've started school, we're looking at in the social and emotional domains, nearly 50% of them are really struggling. They're really not doing well. Whereas with the physical and communication and language domains, the children in out-of-home care are actually doing very similar to those with a substantiation who haven't entered out-of-home care. Now, you might expect them to do worse, because generally to be removed, it means that you've been exposed to more serious abuse and neglect. So, and some other work we've done suggests that out-of-home care is probably protective around physical, language and communication, but it's disruptive, and we're not doing enough around the social and emotional aspects for these very distressed children. Similarly, when we look at girls, the pattern is similar, although the girls generally are doing better when they start school. But again, we're finding the same pattern for the girls, that with the sort of the child abuse and neglect, that they're starting school much worse off than their peers who haven't been exposed to those sort of family situations. Now, that outcome, it's not entirely to do with the child abuse and neglect, as you'll see in some of the other data. Children exposed to abuse and neglect are also exposed to a range of other adversities. So often, and actually we don't have data on, but there will be often other sorts of family violence happening. There's often low education, young mothers, a whole range of, often there's no dad around, much higher rate of children to families where there was no man, no parent on the birth certificate. So there's sort of a lot of adversity in these families, but when we've done studies, we find that the child abuse and neglect overwhelms every other adversity. This is another way of looking at the similar data. It's called, there's a multiple strength index you can get from the ADC data. And again, this is showing that when we look at, it's a bit hard to read the key there, but on the top, what they call emerging strengths, which is a polite way of saying these children are really struggling. And if we look at, so children with no child protection involvement, with the girls, only 12% are in this sort of struggling category, and 26% of boys. Once we get up to children with substantiation, or when they've entered out of home care, for the girls, we're finding 40 and 47% are in this struggling group, and with boys, it's over 60%. So part of, what this says to me is we have to do something before they hit the schools, because once they hit the school and they're behind, it's very hard for them to catch up. When we look at truancy, a similar outcome. So on the left is probably the simplest one to look at. Children, so truancy defined in this case of more than 10 days of unexplained absences in a term. And children with no child protection contact, nearly 11% have had that experience of what's called chronic truancy. But when we get up to the red and the dark green bars, it's actually a bit hard to read the key I'm just seeing, but the red and the green bars are your substantiation with and without out-of-home care, and the same with investigation. So these children, you're looking at, well over 40%. We've got issues of chronic truancy. Out-of-home care is potentially protective, and we can see a bit in the right-hand graph. What this is showing is that if they've been involved with the child protection system early and have been removed for more than 3 years, then their out-of-home their truancy rate is quite a bit lower. But I think, also the out-of-home care is a very mixed bag for children, and lots of things you'll find in the other data. It's because of that huge impact of the social and emotional, they're actually doing quite poorly. So one of the things we've looked at is deaths, and it's really tragic to see, looking at deaths from infancy. So we looked at it from 1 month, because a lot of deaths before 1 month, it's too early to be looking at these sorts of questions, to 16 years. What we're looking at here is for any child protection contact for males. We've got 4 times the risk of death before they turn 16. For females, it's over 3 times the risk of death before they turn 16. When we adjust for other factors, most of which are sort of birth outcomes, that comes down to over 3 times and 2.5 times, which is directly attributable to child abuse and neglect experience. And we can see this sort of increase that even with notification, we're looking at quite high additional likelihood of death. And once we get up to the substantiation or children who've ever entered care, we're looking at 4 to 5 times the risk of death. When we looked at death in ages, so survival to 16, does that mean they're okay now? When we look at deaths to age 33, we find that deep, the sort of pillar box red line at the top, these are children who entered out of home care actually after they turned age 3. And we find that by age 30, we're looking at a mortality rate of 20 per 1,000 compared with children who had no contact with the child protection system of less than 5. So that's sort of 6 times the rate. And we can see it when we look at perhaps if you just look at the first column, which is our sort of rate ratios. So that's really the rate of death for any child protection contact versus none. And we find it's 2.5 times. But if we look at suicide and self-harm, we're looking at nearly 3 times the death rate. Poisons, alcohol, other substances, nearly 5 times the death rate. So this is this social and emotional well-being. I mean, they're sort of struggling. And even natural causes, we're looking at twice the death rate. If we look at emergency department visits, similar story, particularly not so much sort of 6 to 12-year-olds, but once you hit the teenage years, we're seeing the real impact. So 13 to 17, 18 to 24, 25 plus, we're seeing these are just annualised visits, ED visits per person. This group substantiation and out-of-home care just jumps out as they're not doing well. They're much more likely to be in the ED department. And what we've done here is looked at the reason for visits. Let's perhaps look at just the mental health line here. What we've got there, those ranges are the likelihood that they've had a mental health attendance relative to children with no child protection contact. So if we look at the age 13 to 17 years, those ranges, the 7 times is for people just with a notification. The 49 times is children who've entered out of home care are 49 times as likely to have a visit to the ED for a mental health issue. And we're still seeing these massive rates in the 18 plus, similarly for poisoning, self-harms, alcohol, substance use, injury and accident. So the outcomes are shocking. There's other studies that look at, a Canadian study looked at risk ratio for comparing child abuse and neglect, in this case with parental divorce with no child protection contact. So psychotic and bipolar disorders at 5.5 times, depression or anxiety 3 times, PTSD 10 times, and some work in New South Wales looking at, for instance, conduct disorder, 5 times for basically notification, 7 times for children who've had a substantiation, and 21 times for children who've entered out of home care. I mean, conduct disorder, it's not coming from nowhere. These are very distressed children that we're not helping. So, as I said, intergenerational transmission, when you look at the causal pathway, you'd expect to see these sort of children, these people who've had these experiences would be really struggling to parent, regardless of their desperate urge not to want to do this to their own children. Often they are really struggling with their own distress. So what we find, this study, if we look at the left-hand side is the mother. So we're looking at children whose mothers had this level of contact with the child protection system, and we're looking at how likely that child is to have contact with the child protection system of different levels. So for instance, if we look at children who've just had a notification, and the NOC is the notifier only concern, it's the sort of lowest level of notification. but we're still finding these children are 2.5 times as likely to have some contact with the child protection system, 3 times as likely to have a substantiation. And actually, these are adjusted risk ratios, so adjusted for a whole lot of other family adversity factors, and 5 times as likely to end up in out-of-home care. When we get down to children whose mothers had substantiated abuse and ended up and were removed to out-of-home care, we're looking at 6 times the likelihood of any child protection contact, nearly 14 times the likelihood of a substantiation, and 26 times nearly the likelihood of that child entering out-of-home care. So again, we know who these children are. We're not doing enough for them. The other thing that's interesting is complexity, and that's important when we think about what do these children and families need. They need something which is wide-ranging because there's lots of things going on in these families. So, for instance, the red bar is children with 5 to 6 adversities, and we're looking at different levels of child protection contact. So with no adversities, we have almost no, with no child protection contact, there's less than, looks like about 2% of children have 5+ adversities. When we get down to children with substantiation or who've entered out of home care, we're finding we've got over something like 25% of children with 5+ adversities. They're carrying a huge load, these children. So in terms of cost impact, this is just looking at the extra public hospital cost per child per year, or per person per year at different age groups by different child protection contact. So for instance, the teal blue colour, so that's looking at children without a home care and a substantiation. So in 0 to 12-year-olds, that's looking at over $2,000 extra per child per year. 13 to 17-year-olds a bit less. When we get up to 18, 24-year-olds, similarly about $2,500 per child per year. And the 25 to 31-year-olds, we're looking at over $3,500 extra per child per year on public hospital system. We've then modelled that to look at, well, what is this costing the South Australian child protection system? So for when we look at our cohort, 0 to 31 years of age, our estimate is it's an extra $124 million it's costing the public hospital system. That's adding 18% to the cost of the public hospital system. If we model it out to age 65 on some assumptions, we think it's probably over an extra $600 million per year. We're still working on, which is why it's draft, on the budget income support. So this is looking at benefit payments for New Start job seeker, parenting payment, disability support, special benefit, carers benefit. So the annualised income support payments from the ages of 16 to 33. So this is payments per year, is on average for people with no child protection contact, $1,735. When we look at children who've entered out of home care, we're looking at over $8,500 per person per year. So basically, if we're not spending the money up front, we're spending it later on. My estimate is, and this is just almost back of envelope stuff, and it'd be nice to do some more detailed analysis, but I think public hospital cost, I think we're looking at probably over $6 billion per year attributed to child abuse, neglect. Income support, I think over $4 billion per year. Child protection services, this is a number we do know. We're spending over $5 billion on out-of-home care. For instance, the child in residential care is costing us over $600,000 per year. And this doesn't include costs of criminal justice and policing and family violence and housing and school support. I better get a move on. The spend, and what are we spending on therapeutic services? What are we spending up front? Intensive family support services, $550 million across Australia relative to $5 billion on out-of-home care. Child and adolescent mental health services, in fact, it's difficult to get that data. Based on what we're spending in South Australia, my guess is it's well under $300 million a year across the country. We've got maternal and child health services, but most of that is going on universal services. There's very little intensive support for our most vulnerable families. NDIS, there's some funding for children with developmental delay up till age 6, but not a lot of what they do is relational. They're not always working with families. MBS, potentially paediatrician, child and adolescent psychiatrists. We know we sort of don't have enough child and adolescent psychiatrists. When you look at things like the Better Access program, which was to give people access to things like psychologists, this was an example of, I must admit, this is now 8 years old, the data. But when we looked at Better Access up to the age 24, only 2% was spent on children under 5. Basically, some reason we are not supporting children under 5. And some work we did on the mental health workforce, our estimate is that for sort of children, we looked at particularly under 12, we think the service capacity is perhaps 20% of what's needed. We think we probably need 5 times as much resource in that infant child space. So we've got a huge impact on social health and social outcomes, massive budget cost, strong mental health element in this. Intergenerational transmission is the core pathway. Case findings effective. We know who they are, but the outcomes are shocking. We need to do more, especially for boys. So the resources need to be redirected. We're not putting anywhere near enough into vulnerable families. What we're doing, inefficient, ineffective, misdirected, not enough. My view is it's not that we've tried and failed. We actually haven't tried. We're not really putting the resources where they're needed. And I think mental health, intensive family support service, we need much more involvement from there. So essentially what we need things early in life, infancy, or actually from in utero, early middle childhood, and with new parents. It needs to be family-based. We need to find ways of engaging dads. There aren't enough male workers in the sector, in early childhood, in social work. We need to find ways of bringing dads in, and they need to see men in the sector. How do we target? It's important to target the most vulnerable. That's our best prevention opportunity. We need much more therapeutic services. We're doing a lot of case finding, a lot of referral, and there aren't the therapeutic services. Where the speech pathologists, the OT, the infant mental health workers, we need a lot more people in this space who are competent in trauma and attachment theory, who can work therapeutically in those spaces, but also in an interdisciplinary way. What we're talking about is a biopsychosocial problem, and we need a biopsychosocial solution. So we need to bring in mental health together with social supports, educational, special education supports. It needs to all come together. Services need to be responsive because we're dealing with each family situation is different. We need to be able to respond to that, flexible and able to address complexity. It needs to be intensive and well-resourced and scaled to meet need. We have a lot of pilot programs, few families here, few families there. If we're lucky, a few hundred families. We need to be able to support thousands of families. And we need to be able to work in a way that will engage troubled families, which means more outreach, needs to be culturally safe and absolutely non-judging. And that requires actually a very skillful workforce who know how to work sensitively and compassionately with troubled families. And we don't yet have that. So we don't want more dollars into case finding and referral and service coordination. But we do need services on the ground which are capable of working in an intensive way in the maternal and child health space, early childhood, in child protection, parenting, intensive family support, mental health service, justice settings. All of these settings need highly skilled practitioners who can work in a trauma-informed way, so they're not re-traumatising families every time they butt up against a service. Maternal and child health is actually mixed evidence in the sort of things like the nurse home visiting programs. We did a review, and I must admit it's not that recent, but only about half of the programs we looked at were successful. Whether they are depends a lot on whether they understand their target population. If they're working with a vulnerable population, it's no good to just go out and mum and teach her how to bath a baby. They need a lot more intensive trauma-informed work that works around attachment, that works around the mother's distress. So if we're going to do, one of the issues we really don't have in the system is where is this intensive work happening. So we need to invest more intensive live-in options plus outreach. Extended home visiting. If we extend that, it can be quite costly and often not that effective. So we need to think about using our resources wisely. Child protection, we need to be scaling up our well-designed intensive family support services. One of the conversations I had before is a mother who has her baby removed gets no services in most jurisdictions. This is not okay. We cannot be doing this. Partly she'll go and have another baby and it's just unethical to take that mother's child away, and fathers. So there's things around that we absolutely have to do differently. We need to look at reunification opportunities. We can't have all these children in care. It's not necessarily the best option. A lot of children run home. They want to be connected back with their families, but we need to help make that safe. There was a program in pilot, which was wound up, small program in South Australia with actually teenagers, and teenagers had been in care for over 5 years. But they were running home and they worked with family to make it safe. In the end, after 67% was successfully reunified. This is win-win. We can be doing more than that, but it requires a really skillful program to help the families heal in a way that they can become safe places for their children. So there is some evidence of effectiveness with family support programs, and there's a whole range of programs: Circle of Security, Incredible Years, For Baby's Sake, PPACT. So there's lots of things that happen, but often families actually need more than just one of these sorts of programs. So we need to look at how can we ensure that there's access to what families need. It might be a parenting program, it might be social supports, it might be intensive attachment therapy it might be, you know, the other thing is other sort of trauma therapies, you know, within the body, play therapy, movement therapy, art therapy. There's a range of things that we need to actually be able to make accessible. Infant and child mental health services absolutely need to scale up service capacity. There is not services available for, particularly in that under 5 space. It's quite, particularly in terms of skill, there is, interesting, I noticed this new Head to Health initiative that Commonwealth's announced. But at the moment, the amount of commitment to that, I noticed there was a press release, 54 million over 5 years. I mean, it's chicken feed. It's not enough. We need to actually be doing more. Although what's interesting, I know I was just having a conversation yesterday with people in Victoria. The IPC Community Health Centre has combined with Western General Hospital and the Murdoch Children's Research Institute. So that's a very large community health centre. They've got one of these hubs and they're working, I think, in a very biopsychosocial way. They're putting a lot of therapeutic support and they literally are trying to turn things around for very vulnerable families. So I'm very interested to see. I think the other thing I was going to say, I mean, I think it is an exciting time. I think there is an opportunity to get new things out there. And it's sort of exciting to see where things like this sort of program go. Early childhood centres, I think we could do a lot more in the early childhood space. Often they're very welcoming to families. Families don't feel judged in those spaces. Often they provide contact from infancy to age 5. So you've got a chance to create trusting relationships between parents and children and the workers. And often, a lot of the, certainly in South Australia, the children's centres I went to, they do see their remit as disrupting intergenerational disadvantage. They are there trying to help the most vulnerable children. They could offer a one-stop shop for families. So I think there's a huge opportunity to bring more services into that early childhood space. What I'd like to see is more intensive educator to child ratio. For the average child, perhaps sort of 4 children per educator is fine. For some of these children, they literally need one-on-one educators. We need more male educators, high quality training and supervision for the staff, and an expanded interdisciplinary team with infant child mental health trauma specialists, potentially access to medical and nursing, speech pathologist, OT, people specialised in developmental delay, dietitian. Kids need good food, community outreach and social work to work around some of the socioeconomic factors. I think within that space, if we could get more services so that families can access things almost by and by, I think we could make a huge inroad. My guess is if we could put an extra 500 million a year into this space, sounds a lot, but when we're looking at our cost consequences in the billions, it's not a lot. Just looking at, 500 children per centre, 700 centres. If we put in an extra 6 FTE on top of what's already happening, that's about 700,000 per centre. That comes up to 500 million. But, we could do a proper calculation, but I think with a modest amount of money, we could make a difference. This was a program, the randomised controlled trial in Victoria, where they provided an early childhood education program. If we look at that bottom figure there or table, the early childhood education group, children requiring clinical care for social and emotional development at 24 months. This was a very vulnerable group. So 75% of the parents had mental health issues, 50% domestic violence, high criminal involvement, lower IQ in the children. We find that by the end of 2 years of this intensive early childhood service, the early childhood education group, only 12% needed extra support for social and emotional development. A matched control group needed over 40%, and the EYEP group was almost at the general population level. So I think it's exciting evidence that things can change if we can work in an intensive way in that early childhood space. But it does need a whole of government response with a clear remit about which agencies are responsible to fund and deliver, especially around the mental health of infants and children and families. It'd be interesting to consider a needs-based funding. I mean, as a health economist, I was sort of looking in the probably the 90s that needs-based funding in the health sector was very popular, and I think it's an opportunity to look at that again. How do we ensure we get the money where it's needed? And part of that is to go to what's called a fund holding model. So what you have is funders pool their money. So health, human services, education, child protection, welfare. How can we get some money pooled and then used in a child and family hub situation to support our people, children under 6, have fund holder with chief executives, able to deliver and commission services, so you don't have lots of gaps in what we're offering. Nearly at the end. So where does this take us? So something must change for infants, children with child protection concerns to disrupt the never-ending cascade of harms. Prevention starts with the most vulnerable, not the least. Attending to brain health, child development, relational patterning is core. We need to develop fit-for-purpose models. Things like we could look at platforms around early years hubs, maternity care, parent-infant services, intensive family support, but they need to be intensive, flexible, trauma-informed and capable. And we need to have funding models which meet the need, and we don't at the moment. So essentially, proportionate skillful response cannot wait. It's the ethical thing to do. It can work, it can be efficient and save far more than it would cost. And the promise, I think, is to disrupt our most disturbing social ills of family violence, family breakdown, welfare dependency, homelessness, crime and substance use. So nurturing our children, so much to gain from getting it right, so much to lose if we don't. Thank you. So I think if there's any questions, I'm happy to, or comments, I'm happy with comments as well. As I said, there's a lot of wisdom in the room.
Thank you. That was a really great presentation. I just had a quick question about the data. So you were just saying that some of the data suggests that the out-of-home care is protective. I wondered if there was a breakdown between kinship, foster and residential.
That's an extremely good question. I'll have to say we're trying to get some funds to look exactly at that question. Some of the initial work we've done suggests that the kinship is most protective. Although what's interesting also with kinship is you have lower rates of reunification. Often the children stay with kin. But yes, it's a really important question. It's one thing we want to do more work on, is to understand for which children it's protective and for which children it exacerbates harms.
Thank you. And sorry, just a quick follow-up. Is there also a breakdown by Aboriginal and Torres Strait Islander children?
We don't have ethics approval to do work in that space. So yes, it's an extremely good question.
Good evening. It was extremely powerful and informative.
Oh, can you talk up a bit?
Oh, that's the first time anyone's ever said that to me. Professor, have you had much work and intel into the concept that's being driven through health in relation to the first 1,000 to 2,000 days of life, and how your body of work could contribute to that?
In terms of the first 1,000 and 2,000 days and the implication?
Yes.
Well, I think we're not. I mean, I suppose all this work suggests is that the earlier you can intervene. I mean, if you look at in utero, I mean, you know, your outcome of FASD, I mean, those children's lives are destroyed. So I think the evidence around that is pretty clear. In terms of what turns it around, I mean, what's interesting is that, you know, clearly there are programs that work with young children, and particularly with mothers. I mean, I think there's some wonderful programs with, I mean, one of the things is we do all this wonderful screening on pregnant women, and we find who's at risk, and we don't offer them the services. It's actually outrageous. So I think we do know who's at, you know, we do know who's at risk. We do screening, we can find them, and there are good services around. And clearly, you know, I think it's even that in utero, let's get in there and with that first 1,000 days. And there's some of the infant home visiting programs in that first 6 months. There was a great program in Western Australia where they worked with infants in quite an intensive way and got really great outcomes in reducing child protection involvement, for example. Yeah, so I'm not sure if I've question.
Thanks, Leonie, as always, fabulous presentation. One of the things that I think that you spoke about that I think is really underemphasised is the fact that birth itself is often the trigger point for the access to services. And one of the things that we know is that, particularly here in the ACT, is that many of our children are taken into care during the first 12 months of their life. What we also know is that if you're therefore the carer of a child who didn't give birth to that child, your ability to access services is really complicated, and it's reliant on high quality staff to be able to make the connections necessary, and that process isn't systematised. Do you have any tips about how that could be better systematised in a jurisdiction? Interesting. I mean, I think that gaining access to services, yeah, I don't think I have an answer to that. There's probably other people in the room might. I mean, I think even for people who are the ones that gave birth, it's almost impossible for them to access services, particularly the more intensive type. And I mean, it's interesting. I mean, with a lot of places, and certainly in South Australia, I mean, the initial report during pregnancy is considered an unborn baby report, and it's not considered a notification, because the point is they're meant to get access to substantial services, which means then that parent will be able to parent that child properly, but there just are not the services available. And as I said, so it's both when the child's removed, so there's the mother who did have the child isn't getting the services, and as you say, the person where perhaps the child's going to isn't getting the services. So I think we're failing at every level. And I know, I mean, talking to people, say in the, I mean, we've been talking a lot to people in the child protection services within health departments in South Australia. I mean, they have tiny therapeutic capacity to work with these families. I mean, you know, they say, oh yes, we can offer therapy. Oh, they've got 2 FTE therapists. Like, really? You know, so I think that, you know, people say they're covering the space, and that's why I think moving to sort of a needs adjusted formula, and look, here is the population. This is % of people who hit these high levels of need. This is what a high quality service would look like. What level of service do we need? What level of funding do we need to meet the need that's out there? We actually need to do that first principles service planning that is based on need, and where we actually ensure, because I think it's everybody's missing out, because they just aren't. I think we're still focused on the average and the universal, and we're doing so little in that very damaged space. And people need not just a little bit extra, they actually need a lot extra. Yeah.
Hello, thank you. Yeah, lots of great data there. But I was just wondering, like, in terms of, it's really good to see that there's subsidies going to childcare these days, but unfortunately, again, especially in terms of that first 1,000 days, there's not funding going into that first or second year. And it's almost like women have to have a baby and then go back to work within like 6 weeks or 6 months. Like, no wonder there's problems within family.
I think the funding of the early years is an absolute mess. You know, there's long daycare, there's kindergarten, there's lots of different, funding for parents, funding for, it's very difficult for people running services in that space to ensure there's the adequate coverage from, really infancy right through. I actually think the whole funding model needs to change. And that's why, I'd really love to see, can we go to some sort of needs adjusted funding? We've got this many under fives in this population. We know we've got quite good data on level of complexity, both from, your maternity, your perinatal data. We actually know a lot. So I agree. I think the funding in that early childhood space, and particularly for the under threes, is people are missing out who desperately need it. And I mean, part of it is even for, in these very chaotic and troubled households, we need the children, they need to be out. They need to be out of the house. They need to be in a space that's safe, where they're being nurtured, where they can sleep, where somebody speaks to them and doesn't yell at them. I mean, and we're not ensuring that. So yeah, 100% with you.
Thank you. Thank you for a great talk. It's really amazing to hear this. I'm actually the mother of 2 children like this. I'm an adoptive parent, so I want to back that up. But even, I guess what I find distressing about thinking about this in terms of my children is they've had a lot of this input and they still suffer like this. So I think it's really, really important to do it really early. And I think it's really great what you're saying about starting with babies and starting actually it should be preconception actually, not just conception. I mean, that's what the science is showing, which I'm doing a research project on at the moment. But I really want to emphasize what you're saying about services being non-judgmental and avoiding re-traumatization. Because even as an adoptive parent, I have been shamed by schools, services. I mean, I'm literally suffering from it every day at the moment. High schools ringing up, shaming me about my child's behavior, even though I have been entirely honest and clear. And they've accepted the backstory, but nonetheless, institutions are kind of naturally shaming. And I really feel particularly schools, unfortunately, even though I love our school system, this is a good school system, but nonetheless. And I think your message of really trying to take away the blame of parents, parents don't create children's behavior in any direct way. Kids' brains get made in certain ways and they can't stop doing what they're doing. It's not a matter of choice. How many people have said to me, he needs to stop doing X? I'm like, yeah, we're all aware of that, but there's no off button. There isn't an off, and that's what I'm asking you to help me with. That is a very, very difficult message for almost every professional to understand.
Yeah.
And I'm a university teacher, and I know I have students in my classroom behaving in strange ways. I can think, okay, why are they doing that? But most people don't ask that question. They just don't like them, or they want them to stop, or they want them to leave. Yeah. So I think we all encounter these people in our workplaces, we encounter them in our schools, we encounter them in our hospitals, and we need just basic compassion.
Yeah.
That would be so helpful.
Yeah. No, I think that's a really important point. And there's 2 things about it. One is the, as you say, the sort of workplace, or to understand that unfortunately disturbed behaviours that come out of this are often challenging. And it's not, but to understand where it's coming from and to approach with compassion and realise that there has to be another way of working with these families, because if, as you say, if you shame them, they'll walk away and you lose them, or you make it worse because you're triggering them. So the very first thing, do no harm. The very first thing, don't trigger people. So I think that's good. And I think the other reason I think that we have made so little progress in this space is I think it's also a community issue. I think the community's unsympathetic. I think the community's unsympathetic to these families. So I think also we have to look at community attitudes, and rather than, I think at the moment, I think we've got to be very careful in the family violence space that doesn't become an opportunity for further shaming people. And we've got to work out how do we get a message across which is still inclusive and still say we understand we've got a lot of people out there that are really struggling, and what they're doing is not what they want. They don't want to be like that. It doesn't serve them. It doesn't serve anybody. But I think it's a population level as well as a clinical level. Yeah, absolutely. Yeah, great.
Thank you very much. I'm not sure if my question is going to make a lot of sense, so I'm going to try and pull a couple of things together. I think you said, Leonie, and I might have misunderstood when you were going through a number of the programs like Circles of Security and PUP and things that are available, that there wasn't a lot of evidence for extended nurse home visiting as an effective intervention. But then subsequently, in responding to Tony's question, intensive home visiting that's focused on the child. I guess in my, sort of role of trying to make an argument to Treasury to get things funded, and where that evidence sits, it seems to me that we do a lot of things at too light touch a level. So, extended nurse home visiting in and of itself. So we have a pregnancy enhanced program, enhanced parenting program, but it probably isn't intensive enough. And so I guess my question is, in bringing together that evidence, when we identify families who need that support, what, and maybe it goes to the pooling of funding that you were talking about as well, how do we kind of bring together all of the things that are needed, or at a level of intensity that's needed in that first 6 months when we identify that? Because what we tend to do is go, oh, well, we'll do extended nurse home visiting, and that's not enough. Or we'll do this parenting course, but that's not enough in and of itself. I don't know if that makes sense.
I think there's two things. one is often we do borrow programs that have been set up somewhere else. So the sort of David Old's infant home visiting program, I actually evaluated that program that was implemented in Alice Springs with Aboriginal families, and it had some beneficial effects, but you're working with, very troubled families often. And one of the things is that program is very much around supporting the parent around parenting, but there's actually no mental health component at all. So, it's, and also the infant home visitings were actually doing a lot of social work type activities. So part of our recommendation was they actually needed a social worker on the team, and they needed an infant home visitor on the team, because these were things that were actually critical for that population. So part of it is really understanding your client population, and sort of work we did when we reviewed a whole lot of infant home visiting programs was the key to those that were successful, and there only was lining up the target population with what you were doing. A lot of programs you're thinking, this is what you're doing, this is your target population, why would you think that would work? So it's actually being clear about this is a level of, and the other thing is often we're not that good at collecting information, even though I said we do, know quite a bit about adversity, but one of the things is even things like homelessness, when we're not so good at collecting that sort of information. So I think it is really being much better at understanding clearly the vulnerabilities of your population, and being able to respond. And I think also having programs where, there's a concept of whatever it takes. And I think we need to be doing more of that, where you can have an access, here's a suite of things we can offer. Let's work out, let's start here and let's modify it as we go, so we can actually give you more of what you need.
So sorry, now I'm going to ask a supplementary or make a supplementary comment. Just from what you said, I think about the starting point and understanding who your client base is, and work bringing that together with a sort of restorative strengths-based process. It strikes me that even you know, starting with a family group conference or a conference with the parent to build on their strengths, to understand, they know in many cases what it is that they need or what it is that they're struggling with, and bringing that together with professional expertise to actually build that suite of programs for people. I mean, to me, sounds like maybe a starting point.
I think it's sometimes families aren't at that space. So often I know certainly Jackie Amos working with mothers who bring their children in when she was in child and adolescence, the CAM service, child and adolescent mental health service. So the mother would bring the child in and say, fix this devil child, you know, they're impossible. Nothing to do with me, you know, there's nothing to do with family issues here. So, and it took a long time working with these parents before there was any insight about really what was going on. And so once you got to the point of that family has some insight, you're sort of well down the track. So it depends. So I think some families have the insight to be able to engage in that way. But I think sometimes you almost need to offer some services first and get people to the point perhaps where they're able, you know, where they trust you and perhaps can then engage in a more not honest way, but a way that perhaps is really reflective a bit more of what's happening. Yeah. But you're right. I think engaging families is crucial, but I suppose it's working out at what, you know, starting off the level where they are.
Thank you very much for a very comprehensive and very, very depressing lot of statistics. The thing I think which frustrated me most is at the very beginning, looking at all this marvelous stuff we've known about babies' brains for all of this century. We were doing this work in the 1990s and we were terribly excited about where we might get. And I think a fundamental problem in Australia is we do not value children. We see them entirely as their family's responsibility. We blame the families when things go wrong with the kids. And my worry about all the interventions are focused on fixing a problem rather than preventing a problem. The universal services are not universal, other than in the most basic way, the child advice on feeding, toileting, and all the rest of it. There's not, I think you can't get beyond saying support to delight in the child anywhere. And we only know that the money for early childhood education really has nothing to do with children. It's to get parents back in the workforce. It would not be up and running if it wasn't for getting parents back in the workforce. As a grandmother watching my children struggling with small children in the workforce, I think whether you're competent or incompetent, every parent at times is totally incompetent. You need sympathetic support by putting your child in any sort of early childhood education, and the word care is right out of it now too. The parents need support. We are relational animals. We are better in a group than on our own. The humiliation of so many families I saw basically coming to see me because they'd failed. They were failed parents. Everything they were told was failure. Everything that was happening, it was measuring an improvement in the failure. And I think the most shattering one was the parents who were disastrous, including having children who died. We knew from the outset these kids had been in out-of-home care. They'd suffered horrendous abuse. They were turfed out of the system between 16 and 18 years of age, if they lasted that long. Went on to have their babies with nobody offering them anything, anywhere to help until they were blamed for getting it wrong.
Yeah.
We have to value children, and we have to value all children, and we have to be generous in offering extra support, not because you're a failing parent, but we know you want the very best outcomes for your child, and we will work with you to find the things to help you best with your child.
Well said.
I just had one comment about that kind of soft approach, soft touch approach to those early years. And I think sometimes, and I speak as a health professional, that sometimes we do a lot of kind of trying to engage and validating in that. And I think we could probably act a bit more strategically, where if we know that a family has those vulnerabilities, we can engage earlier to those referrals to things like Circle Security. I'm thinking to a client just last week where she only has a 2-month-old, but she's a young mom, 18 years old, who comes from a childhood of her own adversity. And I said, this is the time to start your circles of security, because really, once your little cute little baby starts having a tantrum or something like that, those are the triggers. And I think we tend to take that soft touch approach and try to validate what we're, the person or and empower them to some extent. But I think we also need to really build in systems that support us to be strategic, because I think, like you said, they don't often know until they've gotten too far. And that's really how we can do the prevention.
And I think, I think a lot of it is that people on the ground are seeing parents who are struggling. They know that, but they're really, what do they do? Often they don't have the capacity to work with the families. So sometimes that soft touch, sometimes you do that because actually you haven't got capacity to do anything else. But I think, also we need to think about how do we get capacity. So, I know when I spoke to people in the children's centres, they can tell you which little ones are struggling and which ones need support. In fact, it was interesting, the Child Protection Service in the south in Adelaide. So they're working with, actually a lot of it's with carers, also with children who've been removed, but they did an audit of the referrals they did with particularly the more vulnerable families and children's. They said 1 in 16 was followed up, 1 in 16. So you actually have to be able to provide the service on the spot. We're not doing that enough.
Hi, thank you for. Okay. Can you hear me now?
It's a bit of a struggle with all the masks, actually.
Okay. Is it better?
Thank you.
Thank you for raising the awareness, because I've been working in the next steps as a child clinician. So we have been seeing those, I think, concerns with the family and the children. My comment and the question around is that when we get the, as a community-based service, we do get a lot of complex family and the presentations and then concerns that is not just like a mental health base. Well, there is more things going on for the family. And I want to know in terms of when you, from the research and data, having these early intervention, we know that it's not just only mental health or social work. There's more like a holistic view on that, holistic approach on it, and that having it early is really important. What would that look like? Because what I've, in my experience working with children and family, is just because there is this limitation of the service that we provide. For example, in next step is the mental health and psychological support. So we can't, there's a limitation around outreach, or there's a limitation around how to practically support the family. So I want to know in terms of from the data and research, what would that, holistic approach gonna look like for the family, so that they are just, like sometimes family has to go through hoop to go to the different service. Yeah. And then they have to repeat retelling about all these, I think, difficult experiences all over again. And they have to establish the relationship again. And then sometimes in the process, that some of the family, unfortunately, fall down to the crack.
Yeah, I think part of it is things like as I said, the IPC Health, which is a massive community health centre in Western Suburbs. They've got a set of staff of, I think, over 500 people, a lot of allied health or whatever. So when they're working, and also now linking with the hospital, when they're working with family, they are trying to ensure that they can offer the family what they need as far as possible. And so that people aren't having to continually tell their stories. So I think, and even, you know, colleague Jackie Amos, who works with Centre Care, I mean, they do try to provide a comprehensive holistic service. So I think part of it is if we fund agencies that can offer interdisciplinary wraparound services, I think we need to be doing that. So, you know, at the moment, everything, and part of the problem is that, yeah, people they might need some mental health and they might need some child development support and they might need some around housing. But, you know, some of these organisations, so I think that there are a few models out there. And as I said, I'm very interested to see a bit more where something like this almost Uber sort of community health centre goes. I mean, let's face it, that's where we were in the 70s. The people set up community health centres for a reason, and then they've got really wound up. But I think, you know, we perhaps need to go a bit more back to that model, in fact, but upskill it, you know, and have actually, you know, often they didn't necessarily have the high skill level. They weren't necessarily able to work at the more intensive end, but perhaps that's the sort of, you know, model we can be working around.
Sorry to disrupt this, but I think we've run well over time. Thank you so much, Leonie, for such an incredibly compelling presentation. I do hope that policymakers and the people who hold the purse strings will listen, and that what you say will eventually lead to change, so that the children who suffer abuse no longer get to pass on that situation to their children and their grandchildren and so on and so forth. A really fantastic lecture. Thank you so very much. But I just wanted to thank you all for your interest tonight and for coming along, and to all those online as well. There will be a second part of our fellowship, which will be a peer-reviewed journal article, yet to be written and yet to be published. But when it is, we will certainly be very happy to notify you. To our online audience, thanks so much for joining us. I really appreciate it. And to those present, please do stay and continue the conversation over drinks on the veranda and in the foyer. We'd love to have you with us. Thanks very much, everybody.